All right, welcome everyone to this virtual lecture series that we started a few weeks ago here in psychiatry. And it's my pleasure to introduce Dr. Veerle Bergink, who is professor of psychiatry and head of the Women's Mental Health Program here in psychiatry. She has also an appointment at the Department of OBGYN. I've known Veerle for quite a long time because she was trained in Utrecht as a resident in psychiatry in our department, and then moved on to Rotterdam, where she started actually her career in women's mental health, focusing on the health of mothers and their offspring babies, especially and mothers with bipolar illness and other serious psychiatric illness. She did a PhD in Rotterdam. I was in her PhD committee, and she did extremely well there. And so I thought, we should keep this woman in mind. And when I moved to the US to come here, I asked Veerle to join us. Unfortunately, she accepted after some tough negotiations, and came here in the department and is now doing really well. To wit is what she's going to present now. That's probably part of a grant that she recently got funded by the CDC to study COVID and its effect in pregnancy on the mothers and obviously on the offspring. And I thought it would be very nice to share these very new plans and data, because obviously that's something that's going to be extremely relevant for the near and distant future. So Veerle, thank you very much for providing this lecture with us, and looking forward to listen. Thank you.
Yeah. Thank you very much for the introduction. I'm going to share my screen now. This will take a few seconds. Yes, it's shared now. So I'm going to talk about the impact of the COVID-19 pandemic on mothers and babies and the launch of our Generation C study. And somehow mental health disappeared out of this title, but I'm going to discuss mental health during pregnancy, postpartum, and also in our study as well. I'm going to start with the Generation C study. So in obstetric departments and both at the main campus and the west side, you will find this poster, take part in research in a Generation C study. And we ask all women who will deliver here at Sinai if they want to donate one extra tube of blood during their regular scheduled blood draws. And they will give oral informed consent, so verbal, because at these days research assistants are not allowed at these floors. And we do this because we want to understand the effects of COVID-19 during pregnancy on moms and babies. And women also provide consent to use their medical records and of their babies. And we will follow up with questionnaire and written informed consent later. So this is the design of the study, the Generation C study. We want to include 4,000 pregnant women in total. And we started right at the beginning of this pandemic. I started this because I'm very interested in infections during pregnancy and the effects on the offspring, together with Lotte Witte already. And when I approached Liz Howell from obstetrics, she was immediately enthusiastic and was having similar plans. So we started this study, and now 284 mothers have already been included. So we will investigate the impact of this virus during each trimester of pregnancy and the delivery, and look at maternal and neonatal outcomes. So we will test for IgG by the Kramer lab, who here at Sinai, and IgM during the last measurement. We'll look at the cytokine storm if women test positive, and we'll look in the medical records for many variables and investigate social disparity, and if we can, stress, anxiety, and depression as well. And some maternal outcomes include preterm birth, but also premature rupture of membranes, whether they deliver by C-section, and child outcomes are weight, but also the fetal growth during the at delivery, the weight, and NICU admissions for the neonates and ICU admissions for the moms. So, and when we started this study right at the beginning of the pandemic, there were only very few reports out there, a few case series from China. And now this is changing, of course, week by week. So I'll show you the most recent data of what is known of this virus, the effect on pregnant women and their children. So this is a review from last week. And in these reviews, these are not peer-reviewed, of course, because they're immediately placed online. So not the regular PRISM guidelines, adherence, and so on, all these things. But I still think people do the best they can, and it's still very useful to share these data immediately. So the rate of C-sections is very high, 80%. So these are 441 cases. We do not know from all of them whether they're emergency C-sections or scheduled, so this information is not so useful. 26% is preterm labor, which is delivery before 37 weeks. And you see here preterm birth, 25%. And it should, of course, be exactly the same, but that's because some data are missing of the neonates. And this has, of course, impact for the child also the rest of its life, because we know that preterm birth is associated with many risk factors later in life. Some of these neonates had to go to the NICU because of respiratory distress syndrome, pneumonia, and the vertical transmission rate was estimated to be 8%. And unfortunately, there were 6 stillbirth and 4 neonatal deaths thus far. So this is where we are now, but there are, of course, many unknowns because the numbers are quite low, but we also do not know, are pregnant women more susceptible to the virus than women of similar ages in the general population. The immune system is really changed during pregnancy. I will discuss this in the next slide. So you could think of it both ways. They get it more often or less often. Same for whether they get a milder form or a more severe form of the virus. Clinically, the obstetricians report that 50% is asymptomatic or very mild, which might be even more than in the general population. So when our obstetric department started screening, they are now doing a nasopharyngeal swab for all women at time of delivery. They were quite surprised how high the number of positive cases were because so many women were asymptomatic. But on the other hand, you could also argue the case that this COVID-19 infection might be more severe in pregnant women because that's, for example, what we know from influenza pandemics earlier, and that's of course an entirely different virus, but still we also know from hepatitis E, for example, that more pregnant women are more severely ill. So 1914, but also 1957, way more pregnant women were affected than you would expect based on the prevalence. We have some information of this really symptomatic women with the virus, but what is the impact of asymptomatic infection on the mother of and the child? And does timing matter? Because again, now these days women are tested at delivery, but we do not know what it means if you have had this virus earlier during pregnancy and whether it matters the first or the second or the third trimester. So if the timing matters. So the immunology of pregnancy is of course very complicated because the mother has to have some tolerance towards genetically different fetal tissue, not some tolerance, complete tolerance, which is strange because it's a fetal allograft. So there has to be some form of immune suppression, but not total, because she has to have her defense against viruses and bacteria. And so what happens is that the entire system is completely differently organized, and all hormones, HCG, estradiol, and progesterone, play a major role here. I can make this as complicated as it is, but I tried to keep it very simple. There is a shift towards the innate immune system during pregnancy. And innate is, the macrophages, the monocytes. My promoter used to say pregnant women get the immune system of a snail. So really the basic first line of defense, and the T-cell specific defense is downregulated. There's a prominent role for T regulatory cells to maintain tolerance. And there is also a shift between Th1 and the Th2 balance. These are the T helper cells. It's more towards humoral immunity and less cell mediated, and there's a shift in cytokines as well. This is a very recent study from Sweden, only published a few years ago, and their title was "The Risk Should Not Be Downplayed." And they argued the case. They said, well, immediately, all kind of agencies, including the Center of Disease Control, came out with statements as in, pregnant women should not be worried, and so on, because there are no data showing that it's more severe, and there are no deaths thus far, and which is probably a smart thing to do anyway, because there's so much anxiety out there, especially among pregnant women. But they say the statement is might be a bit too early to say this, because they looked at their registers and their intensive care data, and they found that there are many more pregnant women on intensive care than you should expect on the prevalence rates. And these numbers, Sweden is not a hotspot, so these numbers are quite low. These were 53 pregnant women on intensive care, but the Scandinavian countries are quite good in, being really meticulous in their databases and having their numbers correct. But they said one major problem is not knowing the denominator. So because we do not, universally test all pregnant women for positivity for the virus or doing antibody testing. So this is exactly one of the reasons why we designed the study this way, is to establish the seroprevalence of the virus. And that's why, because there are nationally now some pregnancy registers on COVID-19 positive cases, but we were interested also in all pregnant women, and also in subclinical infections or antibody positivity only, and the immune response at each trimester. So we'll measure some cytokines, interleukin-6, TNF-alpha, CRP, and I listed some of the maternal and neonatal outcomes we're interested in. So one of the most important ones is preterm birth, but also, of course, more severe complications, such as this respiratory distress and ICU and NICU admissions. And an important neonatal outcome is, of course, also the weight and growth. And aim 3 is focused on the impact of social disparity and stress, because this population, those 4,000 pregnant women, it's really a mixed population here. Unfortunately, there are many women of poor socioeconomic background. We know that women of color have a higher risk of getting the virus, having much more risk factors. And well, this is a really mixed population, so we can investigate what the impact is. This is the model, so we'll investigate the impact of the virus on the mom and the child. And we know that it's not the virus itself, but the immune response of the body, which has an effect on how ill the mother will be, but also the cytokines have a possible effect on the developing fetus. And here comes social disparity in. To start with, women, from poor socioeconomic background will have more often the virus, because many pregnant women flew out of Manhattan to family elsewhere or at Long Island and could keep their social distance. But if you're in a small apartment, you cannot do this. You get the infection. Social disparity is associated with multiple comorbidities, including diabetes, hypertension. This is, of course, very problematic during pregnancy and for having this virus, but also obesity. These fat cells produce those cytokines. And we know this is also related to adverse outcomes and other factors, much more stress, financial stress, and so on, which will impact maternal and child outcomes. And in this study, we will not have, we have some information on maternal stress because obstetricians should screen for prenatal and postnatal depressions, and they do, so it's somewhere in a medical record. And we're in the process of sending out questionnaires and getting this up and going. But it's important to know that we have also a data set from Europe, and they will share data with us and send samples. And in this cohort study, it's called the Brabant study, we can, this is an ongoing cohort study. So this study started before the pandemic. And there are, of course, many birth cohorts worldwide, also investigating mental health. But this is one of the few, or maybe even the only study that really continued inclusion, because just as in this hospital, when the pandemic broke out, I think worldwide at many research hospitals, inclusion stopped for all clinical studies if it was not immediately COVID related. So the Brabant, I've lived there for many years, but it's one of the top 10 hotspots, unfortunately, affected regions in Europe. The south of the Netherlands is Catholic, and they celebrate Carnival. And this was not such a great idea at the beginning of the pandemic, and that's why there are so many cases. And this cohort, this ongoing birth cohort, happens to be in the middle of this region. And they have very detailed online mental health assessments and sampling during each trimester of pregnancy, so we can compare before and during. And of course, we already know that women are much more anxious and depressed during, but it's still good to investigate. Or depressed, we don't know, but at least anxious, because that's what we see, and we know everyone is anxious these days. This is the research team. It's Helen, our PI, and you might recognize the people from psychiatry, so Lotte Witt and Anne Rommel and Nina Molenaar, and obstetricians are doing a fantastic job. For example, Joanne Stone and Whitley Leap, we're having daily meetings at some point, and they were really treating patients in the hospital while we were, sitting doing telehealth for our patients, but not having to be there. And Teresa Genevieve and Rhoda Sperling, and this has been a great team. And I think for us as psychiatrists, it was, we were interested in this study because we were already interested in the impact of viruses in utero on the child, and especially long-term effects on brain development. And just to give you some background, what we can expect, because I think it's interesting to think about what this virus might do, what we will see many years later from now. We know from the animal literature that if you inject a mouse with a virus or bacteria, this will result in a cytokine storm. And if you sacrifice the animal, you see structural brain abnormalities, as well as reduction in brain volume. And if the offspring, if you let them live, people have done all kinds of behavioral tests, and this is abnormal. So clearly, and they even call it autism-related behavior, whatever that may be in a mouse. So it's clear that these experiments lead to behavioral changes, and these are quite severe. But it's also good to know that these animals are injected in high doses, so they're almost septic. So it does not directly translate to humans, of course. And also if you inject cytokines itself, so it's not the virus itself, it might be the response, those cytokines, this led to similar outcomes. And in the animal literature, there's great interest for interleukin 17. So that's something we proposed in our grant proposal before this pandemic broke out. Epidemiologic studies showed that infections during pregnancy give an increased risk on psychopathology later in life. The first studies were focused on this influenza pandemics, and they showed as outcome increased rates of schizophrenia, but many more studies followed, also studying other infections than influenza, and even urogenital infections, for example. This occurrence was associated with psychopathology, and they also studied not only schizophrenia, but also bipolar disorder, autism spectrum disorder, and unipolar depression. So yes, there is evidence that we can expect an effect in humans as well. We propose to do a study and looking at brain changes after infection during pregnancy using the Generation R cohort. We had pilot data showing that infection during pregnancy, so this is of course not COVID related, these are just the regular infections we had 14 years ago, because this study started 14 years ago. The children are now 14 and there are 4,000 brain images of these children, and these are pilot data from age 6, and the moms who reported infections during pregnancy, those children had some structural brain abnormalities in the temporal lobe. And we'll also investigate, or we plan to, don't know if this will be funded, of course, but this was the plan, and this was the interest before this pandemic brought out. So how does infection during pregnancy has an impact on brain development later in life? And it's not only the virus or the infection itself which will have an impact, but it's also, and this is a slide from Rachel Yehuda, who kindly offered to help me with these kind of studies for later on maybe. But it's known that stress during pregnancy will have an effect on the offspring, and maybe even in multiple generations. There's an intergenerational effect of stress, and this was already known that stressful mom has an impact on the baby, and this will lead to risk of psychopathology later in life. But we realize more and more how important also the stress in utero is. So these are all, I think, interesting thoughts for thinking about future research. Yeah, it's of course interesting, but it's very tragic as well that this whole pandemic will have so much impact on all levels, and even the next generation that is not even born yet. This is a paper which was just accepted in JAMA, and this is together with all mental health directors in New York who worked a bit on this. In the end, we wrote it with only a few people because it was a viewpoint, but it was, the mental health needs during this pandemic are huge because everything changed. The women who deliver these days, they deliver in a super scary environment with obstetric staff fully dressed in PPE. In the beginning of the pandemic, the partners were not allowed a delivery. So there were immediate some changes, and we tried to come up with a plan what to do to make everyone's life a bit easier, because women are at very high risk of post-traumatic stress syndrome after such a delivery. And in every I think change in policy, people should also think about what it means for the mental health of the mothers. This had impact on many levels. For example, many women decided to try home delivery because they're so scared because of the hospital, which is not a great idea because 911 is really busy these days. And so there are all kinds of changes which have an impact on mental health and where we can help to reduce anxiety a bit or treat women with mental health disorders. And at any time, it's very important for perinatal psychiatrists to make a plan for each woman, what to do during pregnancy, what to do during delivery, and what to do postpartum. But I think especially during this time, because everyone has a complete loss of control, right? We do not know how long this is going to last. We do not know whether you get the virus or not. But especially this loss of control is very difficult for pregnant women who know they want the best for their child. And so if we make a detailed plan what to do, then this gives some guidance. And also many women move across the country, but then they can bring it with them. I think I already discussed the most important thing in this paper, and it's good to know that in terms of change of mental health services, of course, everyone switched to telehealth, including ourselves, and these are the plans I discussed, and I will shortly summarize some medication recommendations in the next slide. Quickly going to see how I'm doing in terms of timing. So anxiety, depression during pregnancy and in times of COVID, everyone is anxious these days, pregnant women also. As I said, obstetricians should screen, but also I think for all of us mental health professionals, if you see a pregnant woman or postpartum, please screen, and the EPDS is really easy to do. If you type into Google EPDS online calculator, then you get an easy to fill in questionnaire. It only takes 5 minutes. You get a score. You can also do it yourself if you want to check on your own mental health. This is a questionnaire without all the items which are a bit pregnant sensitive, such as loss in appetite or weight gain or sleep loss or libido, because these are changed during this period anyway. But it gives some not a sense of if someone is anxious to start with, because we're all anxious, but how severe it is. And in terms of treatment, we earlier did a review what the guidelines say, how to treat women with anxiety, depression during pregnancy. New episodes during pregnancy or postpartum should be treated with psychotherapy, and this can be done via telehealth. And it doesn't matter that much what you do. I mean, there is some evidence for effectiveness of every therapy, most evidence for cognitive behavioral therapy, but I think many more other interventions are good to do as well, yoga, mindfulness, whatever people do these days, but it is important to do something to get some sense of control. For more severe episodes, the preference is sertraline because the levels are lowest in breast milk, but it's good to realize that the levels are low in breast milk for all SSRIs. And so if a woman is using other SSRIs, 10% of women in their fertile ages are using antidepressants. So many who walk in the door being pregnant already have medication. You should not switch. One of the main questions is, should you continue this medication during pregnancy or not? This holds true for all psychotropics. And of course, it's easy to say these days, well, just let us continue everything. But, we should continue medication if we're worried, but I still think we could think about the effects meds have on the next generation, just as the effect stress has. Medication past the placenta will have some effects. So the dilemma is always weigh the risk of relapse versus child outcomes. The relapse risk after discontinuation during pregnancy, it's not so clear. There's one study showing, yes, women relapse. There's another study, population cohort. They say there's no difference in relapse rate. So this study, the data at least suggests that women can safely taper. And there is even a study showing the opposite, that, women who continued antidepressants were more often had episodes. But these authors said, yes, but these women were most ill to start with. That's why they continued their antidepressants. So maybe this is known for everyone, but as a reminder, the short-term outcomes after antidepressant use, this is associated with lower birth weight, preterm birth, poor neonatal adaptation, but this is usually mild. And it's good to realize that stress, anxiety during pregnancy is also associated with low birth weight and preterm birth. One SSRI-specific complication, which is very rare but quite severe, is persistent pulmonary hypertension of the neonate, but that's really rare. Anna Rommel from my group just did a review on the long-term effects, and I will show you the results. Antidepressants cross the placenta and the blood-brain barrier, so they also have an effect on the brain of the child, same as infections during pregnancy. There is was no association with adverse physical health outcomes. The data with childhood overweight are a bit inconsistent. There is nothing on neurodevelopmental outcomes which should be of any worry, but the quality of evidence is very low for cognition, behavior, IQ, and motor development, unfortunately. Same for autism and ADHD. There is no clear association, but the quality of evidence was low for autism and ADHD. Recent studies showed an increased risk of depression and anxiety, and these are really large birth cohort studies, and they controlled for the underlying indication. So control groups were either siblings or moms who discontinued antidepressants or moms with the disease, and they controlled for this, but still there is and one of these studies is ours. We did find an association with increased level of anxiety and depression in the next generation after in utero exposure to antidepressants, but we still do not know, of course, whether this is causal. So we should individualize this. What does it mean practically in these times of COVID? I think you should just go with what the patient wants, basically, maybe at these times, because, you know, patient have already stopped because patient walk into the door and they have already tapered their medication, then it's reassuring to say that, you know, that the relapse risk in the literature are not high. We don't expect these. But also, if they really want to continue, then you can say that the risk of the child are really low, no congenital abnormality. So I think it's important in these days that we are really reassuring. Alternative treatments, psychotherapy is of course also possible. I wrote advice against strict self-isolation at home, and that is because, you know, some pregnant or postpartum women are really, they're not going outside at all. And I understand the anxiety of the virus, but I think for levels of stress and anxiety is good if pregnant and postpartum women go outside sometimes, because, you know, patients are in a very small one-bedroom apartment with a toddler and being pregnant, and then all day, and that's very stressful. And the risk, if you are outside and keep social distance, of getting the virus is not so high. So for patients with OCD or panic attack, in general, it might not be a good group to taper antidepressants because they really need these really work well for panic attacks. And these days, OCD is really high, where we all are, obsessive all the time. And so it might not be a good idea to taper medication. When it comes to benzodiazepines during pregnancy, these are not teratogenic. And of course, it's tempting because women are so anxious to prescribe these, but I still think we should not do this because, you know, there are associations with preterm birth, C-section. It's the same receptor as alcohol. It's not so great. And also we know that it on long-term use, of course, is highly addictive, will not do much for your mood. Antipsychotics are often used as sleep medication because of their side effects. Their side effects that they make you sleepy a bit. And I think that's not a good indication, especially not during pregnancy. So only use this method for people who really need this. People with psychosis or mania in history, Antipsychotics are not related to congenital malformations. There is a relation with preterm birth. Atypical antipsychotics are associated with gestational diabetes, so they should be carefully checked. And again, many patients need this. They have antipsychotics for a reason, because they have schizophrenia or bipolar disorder, and we should continue these and not switch during pregnancy. Always search for monotherapy. And the long-term effects, I think there are some effects. These medications pass the blood-brain barrier as well, and the placenta, but it's very poorly investigated. I'm going to spend a few more minutes, and that it will be the end of my talk, on bipolar disorder, because this is really the high-risk group. And it's only 2-3% of our pregnant population, but these are the patients at very high risk. So all our other patients are, not specifically high risk postpartum. There is some debate whether this is true for depression, but the numbers are not going up very much. Basically, women are depressed all the time. But for bipolar disorder, it's a really different story, which is again shown by our very recent data. This is a paper in preparation, 919 pregnancies from the Netherlands, and we looked at all kinds of reproductive events. And in this study, we found the episode number during pregnancy very low, the risk after delivery very high, 40%. And this is the first paper in which we looked all events and compared these. And then you see that miscarriage and abortion also leads to episodes. And this says something about the underlying biology, that specifically the change from pregnancy to postpartum triggers episodes. So this risk, what we found, everyone else finds it as well. That's what we showed in a meta-analysis. The risk is 1 out of 3, super high. Women get very ill. Every bipolar patient who delivers should get prophylaxis immediately after delivery if they do not already have this medication, or at least it should be discussed, I think, if they have a severe bipolar disorder. So lithium is first choice. Antipsychotics are widely used as well. And the same holds true for women with postpartum psychosis. They really should start medication immediately after delivery, and I think that's important. For other mood stabilizers, valproate is highly teratogenic, should not be used in women in their fertile ages. Carbamazepine to a lesser extent, and lamotrigine is not. Our very recent data showed lithium is teratogenic, but only in the first trimester, and the risk is lower than previously thought. So for lithium, try to go really low in the first trimester and make sure the dose is high right after delivery. Or some women might want to taper. I think I discussed antipsychotics and the increased risk for gestational diabetes and the uncertainty about long-term outcomes. This is our mental health program. So Matthew Dominguez started seeing patients in person in the E-level clinic at the Klingenstein Pavilion because telehealth did not work well or they couldn't set it up. And Dalia Robakis is seeing many patients. I'm not so many, so she's reading this program very well. So big thanks to both of them, and also because Dalia will help us a bit out probably with the Gen C study and the follow-up. I also want to thank all these people, and this is only the team who started this. Many more researchers are also, if they have interest in this, welcome to join, and also the people here who did all the work which is needed for such a big study, including Amy Balbieres. And yeah, so this is my presentation. Just a reminder, this was the Gen C study. And the CDC funding is pending. They approved the scientific context, but we are going back and forward about the last details administrative. So that's good to mention. And also many thanks to the Friedman Brain Institute who made it possible, and some philanthropy for us to start this right away. I thank you for your attention.
Thank you very much, Veerle. That was a great and a very comprehensive presentation on the COVID study and in general how to take care of our pregnant women with mental health problems. Thanks very much. as you see, there are below you see Q&A.
Yes.
Screen. So there is a question if you and people. So there is one question, but if other people want to ask a question, you can put that on chat as someone do and on Q&A. So Veerle, if you want to pick up the question and read them and answer them, thanks very much.
Yeah, so there's one question, do Sinai test all pregnant women? What percentage is COVID positive? Yes, so they only test them at delivery. So we do not know if they were COVID positive during pregnancy. And the latest rate from obstetrics they said at some point, you know, we talked to them, they were all dressed up in gear and they said 20% is positive. We're really panicking. 20 to 30%, that's a lot. I spoke to the neonatologist, Annemarie Stroestrop. She said, oh, the numbers are lower because we do not see that many babies from positive numbers. So yeah, that's why also one of the reasons why we need this study to really get these numbers out as soon as possible, but it could be quite high. I see here two things, question and answer. Is the study going to involve education of pregnant and new mothers about the potential impact of COVID on their child mental health and what the family could do for prevention? Yeah, I think it's an excellent point, but we can only do education if we know enough. And I think, you know, the risk thing is we don't want to worry women without having, you know, this evidence, and we should not worry them at all. But of course, this will be disseminated. And this is also, you know, one of the requirements from CDC to fund this is to not only get this data out, but get this, you know, out for the target population for pregnant women immediately. Will this presentation be available for viewing subsequent to the lecture? I think so. Will you assess alcohol and drug use in the pregnant women? Yes, we do, but so we take it from the medical records, but we're now also working on a questionnaire and sending this out. But then women have to do something. So they have to provide written informed consent. We can do this online, but we're in the process of doing it, and now we have hopefully more detailed information on alcohol and drug use, but it's in the medical records as well. So yes, we have this. It's great. You also focus on minorities. We've seen other initiatives struggling with including them. What is your approach? Well, our approach is that everyone who steps into the office of the obstetrician will be asked to donate one extra tube of blood. And they can object, of course. They say, no, I don't want to do this. And then these women are not included. But they are explained, you know, your blood will be used for COVID-related research. And then your medical record will be reviewed. And these days, women do find this important, women of all socio-economic class. And so they all participate. But the big challenge is, of course, if we design any follow-up study for their children, how to keep women motivated and how to enroll women. And I think it's important to have some reimbursement for their time, but also, you know, strategies to do this. Answer this. Oh, I think those were most.
Cheryl. Actually, there are two.
Yeah, for association between flu during pregnancy and outcome in offspring, it seems the cortical purification effects are in temporal regions that include language region. Is the increase in autism system specifically language one? I don't know. Do you expect similar findings for COVID-19? I don't know. Sorry, Cheryl, but it is interesting that when we corrected for autism, the things disappear. So this really suggests this association. But I'm not a neuroimager and team up with very good neuroimagers, so I should ask this question to them. Amy, excellent. Have you seen any trends related to maternal antibodies and COVID? I don't think this has been done yet because, and COVID, between maternal age and COVID. No, I don't know. I don't know. Maybe it is there in this review. My guess, of course, would be that, you know, being an older mom doesn't help, because then you have a higher chance of having comorbidities such as hypertension or pre-pregnancy diabetes. But I don't know.
Okay, I think that's it. Sure. Veerle, I think we've had all the questions. Any other questions that people want to address? Can still do so.
Oh yeah, and I think Joaquin suggested that someone could raise their hands.
Oh, you can also raise your hand.
I don't know how this will work, because I can only see Dr. Cavid, Dr. Boxbaum, and not the others. So.
Well, everyone can use. Oh, there's another question. Yes. From Korea.
Oh, I thought Cheryl raised her hand. She's going to come up with another difficult imaging question. Thank you, Cheryl. And then I should unmute you, right?
She raised her hand.
Or not.
I just wanted to see if it worked or not. That was a great talk.
Oh, thank you. I thought you would come up with another difficult imaging question, Cheryl.
It was a fantastic talk. Thank you.
And then it's so nice that you can quickly mute people again, right? If it's going to be really challenging. Thank you, Cheryl. Thank you so much.
There's another question in the Q&A.
Okay. Is it possible for you to add cord blood and or placenta collection? Yeah, we try to add cord blood, but obstetrics in our protocol for verbal consent, they say then we have to switch to written consent, so we cannot do it. But yes, we would like to do this. There is placenta collection ongoing in the lab of Rachel Brody, and at some point we should talk and discuss how to do this. But the first step for us is to come up with a written informed consent form, asking women for permission to use this biomaterials and send this online. But that would be very interesting and important.
Okay. All right, Veerle, thank you so much. It was a great talk and a great interaction as usual. We had, again, more than 90 people in the audience, so that's super. Thanks very much. Good luck with the research, and hopefully see you next week. Next week we'll have Cheryl Corcoran presenting on the analysis of language in the detection of COVID, and she has a very famous example, namely Boris Johnson. So don't miss it. All right, thank you.
Thank you, Veerle.
Thank you, Veerle, again. Bye-bye.